Thank you very much. Let's see if I can manage the technology here. With the first thing, I guess, is how to make it go to the next slide, or the next presentation. Spacebar. Okay, thank you. So, what I'd like to do is to give you just a little quick whirl through the history of a little bit of this, and tell you why it's been a lot of fun to do this. Patients are great when you can't fix the problems, so you keep looking and trying to figure out, well, how are we going to do this? How can we do this better? And I've had just awesome colleagues here at Lankenau and elsewhere to do this with. And again, at least as far as I was aware, for many years, Dr. Eisman is my idol, and from afar. So it's been quite a run. So what's happening? Well, the trends is the increase in incidence, just that we have better diagnostic methods. Certainly we do bronchoscope more patients, or at least we used to. Actually, the incidence of doing bronchoscope in patients is a little less now. But CAT scans, of course, have increased diagnosis somewhat and helped us try to figure out what's going on. Treatment algorithms, how do they apply to community practice? We've played with that quite a bit over the years. And what's the prognosis? Somehow it seems like our patients have done much better than I would have expected, and I don't take credit with our treatment as much as I think that we may have maybe a little bit of wimpy Macs around here, and of course, unfortunately, mixed in with some real tough ones. So how do we distinguish, which ones are going to be the easy ones to fix, which ones are the tough ones? And that's one of the challenges that we face. Does one size shoe fit all? So how this all came about in the early 1980s when I got here, I'd go back to my mother house, Hospital University of Pennsylvania. We'd had our conferences with some of the famous leading lights, Dr. Alfred Fishman, Wally Miller in radiology, Steve Albelda, John Hansen Flashen, amongst the many folks. And we'd talk about some of these cases of Mycobacterium avium. They were always of interest, a little different than the usual. And then in the mid-1980s, when we developed our academic affiliation with Jefferson and the Division of Pulmonary, far ahead of the Jefferson Health System, although we don't necessarily take credit for forming it. Yes, we do. But Dr. Figueroa, our guiding, as I say, godfather of pulmonary at Lankenau, Jim Fish at Jefferson, Harold Israel, John Farber in pathology, and David Prince at Jefferson. David, are you here today? I know David was trying to get over here. He's at Jefferson now. So we as we talked about these cases, cough, sputum, many years, significant minority progressing to fatal lung disease. So we did have some tough ones, and it was very frustrating. Somebody described the Lady Windermere syndrome. Thin elderly women, they didn't cough and spit because they were too fastidious. Now, if you can't figure out how to fix the situation, well, why not blame the patient? And it didn't take long looking at the situation. I thought, well, this is ridiculous. This is not what's happening. It's not their fault. But then things got worse. In the 1980s, everybody was worried about HIV infection whenever MAC was grown. So when the cultures came back, the patients were often counseled and tested for HIV. And hopefully, it could be frightening, and hopefully nobody disclosed indiscretions before the results came back negative. And we said, this is ridiculous. We've got to help these women, mostly women, women. So in 1989, in the New England Journal of Medicine, this paper, David Prince at Jefferson was the first author, and he and I collected about a dozen cases from Lankenau, a dozen patients from Jefferson. So we had the inner city hospital and the hospital out here, and it kind of described the prototype of a different kind of patient with Mycobacterium avium complex. The editorial for that paper was written by Dr. Eisman. And it's been fun to talk about this many times since then. So there were, as you know, the usual HIV, the thing we were worried about, structural lung disease, and then the normal elderly women that we were, of course, the focus of our interest most of the time. And we saw that MAC was much more common now, and this is the incidence of MAC cultures at Lankenau in that range before we published our paper, steadily increasing, and then at a later time frame, just by comparison, here we are in more recent years. A different graph, as we also found, tuberculosis remained very low. It was already at a low level in this community in the early 1980s, and it's remained so, whereas now this is the incidence of MAC infections as of 1996. So this is already when they had kicked up to a fairly substantial level compared to our initial, when we wrote our paper. And then you see it has gone up further yet, where tuberculosis, of course, has remained at this low level in this community. So why is this happening? You've heard a little bit about this. And of course, there are a number of reasons which I won't go into. We'll hear a little bit more about them later. But normal elderly women, let's focus on them. 80-90% women, mostly late, middle-aged, elderly, thin, Caucasian women. And there's a lot of them around here. So I think we have a lot of patients here. The epidemiology is similar in most developed countries, including Japan. We have a fair amount of literature from Japan. Little data in Africa, but in this community, we do take care of a large number of African American patients, and even for the thin, elderly women, African American, it's very unusual. In fact, one of my patients was later discovered to have CLL, and a very vicious form of it that eventually was the cause of her death, so she dropped out as being my only patient like that. So what's the difference? Now, this is Dr. Landy's slide. She took out all of my offensive slides, and you see the high risk, low, very easy to remember. Oh, thanks, Leah. And then some data that really Rebecca and Leah have worked very hard on with Janet Sawicki and with myself, and she asked me to present a little bit. So what is this? Hormone deficiency? Is it about the estrogens? What is it about postmenopausal women? Is it the environment for growth of the mycobacterium, or is the response to it? There's got to be something here. There's a huge signal. And of course, we note that the decline in hormonal replacement therapy over the last decade correlates. Here's our MAC cases versus the TB, and then here's MAC cases versus hormonal replacement therapy use in the United States for women. And of course, after the big report in 2003, the incidence dropped dramatically. And so there you have it. There's a correlation now. I'm not great with these things. Maybe I could have shown the same thing with chocolate or caffeine consumption or whatever the current fad is to correlate with something. But we think that there is a signal there, and we'd like to see if we could go a little further to elucidate that. And some others have looked. And so we know that women with less adipose tissue have lower estrogen levels. You know that if you take the ovaries out of mice, they get more severe disease if they're challenged with the pulmonary MAC infection. And if you give them exogenous estrogen, they're not as sick. We looked at DHEA, the pro-hormone for the estrogens, which declines with age and lower if you have less adipose tissue. And also they've correlated low DHEA levels with active tuberculosis, with a tendency to develop active tuberculosis. In mice, if you give them DHEA and androstenedione, they actually have less severe tuberculosis. So there's some animal work, some suspicions in humans. So we've been drawing blood from a number of patients with Mycobacterium avium disease and measuring DHE levels and estrogen levels just to see if there was anything obvious. And the one thing that did stand out, that the DHE levels for our MAC patients were approximately half of the levels for controls. Our controls aren't perfectly matched, although when you correct for the difference in BMI, it's still very significant, and for weight as well. A few of the women had almost unmeasurable estrogen levels, and so we're trying to figure out if there's something special about these women. So we're looking further into this and trying to see what may shake out. Is there going to be the possibility of a treatment based on this? Where are we going from here? Of course, since DHEA has a lot of effects in the human body. Now, a few other things, treatment algorithms, national guidelines. Do you have to use a 3 or 4 drug regimen or watchful waiting? Is it one or the other? We've, as many of you know, we've worked with this a little bit, and we're very cautious. We don't have anything to publish because there's a problem. So many of these patients you treat, they're better, they're really better, and 2 years later, they have it again. Now, what's going on? I mean, why do they have it again? And, we couldn't tell. It's MAC is MAC, right? Or microdermavium. We could do sensitivities. They were sensitive. So how do we know what we were doing? We didn't have any way to really figure this out scientifically. You know, was a bug still in these patients all this time, even though they appeared to be totally well and symptoms gone? So how do we distinguish recurrence versus reinfection? I was convinced that in most of the patients that don't have overwhelming disease, that if they got it again, it was a new infection from outside. The sources we're talking about. The severe patients and much more difficult situation, cavitary disease, but still without the proof, how do you tell one from the other? We were stuck. I felt like we got nowhere and made very little progress in this arena and couldn't really make progress without endangering the whole situation, because we didn't want a whole bunch of patients with resistant disease coming along because they were undertreated. So I'm hoping that at some point we'll get to where maybe we can talk about less intense treatment regimens for patients with less severe disease. Maybe we can talk about treating earlier without blasting them with medications that make them much sicker than they were to begin with. Maybe this will happen, but we need methods. We need methods to find out. And of course, that's I won't go over this, but that's where the speakers here come in. We now have some weapons to try to tell one bug from the other, and to try to figure out which ones are worse one than the other. We've really got some chance here to move forward, and I thank the giants in the room who have taken us this far and still are continuing. And of course, Mike Eisman, you used the R word last night, and I didn't like it. People here know that I don't like the R word. I've discouraged many people. So I hope that something comes up that makes that not happen. And Philadelphia is a good place, you know. So I think, and in the last part, Dr. Landy, Dr. Sawicki, I'll leave. Leah, you'll tell us the next bit.